I've been asked to talk to you a little bit about the latest developments in mesothelioma. But since this is a mixed audience and not all of you, of course, are physicians, I thought I'd start out with answering what is malignant mesothelioma. And this is a cancer of the lining around the lung, the pleura, around the abdomen, around the heart, or around the scrotum that is principally caused by asbestos. This is what pleural mesothelioma looks like on a CAT scan. Just picture that gray thing just wrapped around that lung, squeezing that lung, making it tough to breathe. This is what it looks like in a surgical specimen wrapped around the lung, and then microscopically, the three subtypes, the epithelial, the sarcomatoid, and the mixed mesothelioma. And who gets this disease? About 2,500 to 3,000 cases a year in the United States, about 5,000 cases in Western Europe, and as later speakers will tell us, it is an emerging problem in the developing world where there are fewer asbestos regulations. The onset is about 20 to 60 years following asbestos exposure. We believe that the incidence peaked in this country in the year 2000 and will peak far later in Europe because their asbestos regulations took place later. Reflecting occupational exposure, males are more commonly affected. And here it is a disease of the elderly. The median age is 74, and 72% of the patients are over 65. And reflecting workplace discrimination in the higher paying building trades, it is actually less common in African Americans. So this shows you the relationship between the asbestos consumption and mesothelioma incidence 20 to 40 or even 60 years later. Shows you how men are more commonly affected and how African Americans are less commonly affected. So what's new about mesothelioma? As I tell you what's new, of course I have to tell you a about what's old. But what's new include data on biomarkers, some controversies in surgery and multimodality therapy, and I'll end up talking about chemotherapy and targeted agents. First on biomarkers. So there is a new biomarker out there called mesothelin. This is something on the surface of the normal mesothelial cells, and serum mesothelin-related protein, or SMRP, is what's found in the bloodstream. And it actually is commercially available, although not insurance reimbursable, as something called Mesomark. So in Wittenoom in Western Australia, there's a collection of serum dating back up to 30 years in an asbestos-exposed population. And in this population, it was found that elevated SMRP levels were detected most in the mesothelioma patients and not in people with other lung diseases. Now, it's elevated in patients with meso, but as you'll see in that circle in blue, in patients who were exposed to asbestos but did not yet have meso, those who had elevated levels subsequently developed meso up to 6 years later, suggesting perhaps a way to screen for the disease. In patients who have meso, you have higher mesothelin levels with larger amounts of tumor. And those mesothelin levels will decrease once a patient has surgery or successful chemotherapy. And some data suggests that the mesothelin levels will correlate with survival. So that suggests a number of potential uses for SMRP, and those could include screening, diagnosis, determining prognosis, monitoring the disease. Now, SMRP is only useful in one of the subtypes of meso, epithelial, and certainly further studies are essential before it hits prime time, but it is very exciting. Another new biomarker is osteopontin, similarly a glycoprotein that also has a number of potential uses, including diagnosis, determining prognosis. The lawyers like the one about quantifying asbestos exposure, and this too has key limitations. It is elevated in both subtypes of meso, but it's also elevated in other cancers, so it discriminates a little bit less well. Moving on to controversies in surgery and multimodality therapy. In most cancers, you know when you're going to operate, you know why you should operate and in whom you should operate. In meso, it's less clear what the role of surgery is, and that's because it is basically impossible to remove all of the tumor from the lung. It's a very sticky tumor. So the decision about whether to do surgery and which surgery to perform is truly determined by the doctor's bias. What are the surgeries for those of you not in the know? Well, one is a thoracoscopy. This is a tube inserted between the linings of the lung, and we put sticky stuff between it, between the two linings to help a person breathe better. We use it also to diagnose, but it is not a therapeutic option. The results depend upon what else you do. The most aggressive therapeutic option is the extrapleural pneumonectomy. This removes the two linings around the lung, the lining around the heart, and the diaphragm all in one piece. Not something for your average 85-year-old. The patient must be physiologically fit. It's not advisable for the more aggressive sarcomatoid histology because it comes right back, and it's debatably effective if the lymph nodes are involved. It is indeed a risky surgery that must be done in very experienced hands, but it is the only surgery that has the potential to cure, although usually, unfortunately, if the patient's not selected properly, most of the time the cancer comes back in a year. The other surgical option is the pleurectomy decortication. I describe this to my patients like peeling a grape in a box. You're peeling the lung, but the lung remains in place. And it's great for patients whose lung is crushed and crunched by that pleural peel because it enables the re-expansion of the lung and they can breathe again. Patients don't have to be as healthy as for the extrapleural pneumonectomy. It's not a curative, it is a palliative surgery. Now, which one of these is better? You'd think is the more extensive one should be better. But actually, in what's called a meta-analysis, there is actually no statistical difference in survival by procedure at any individual stage. So this looks at an analysis, a recent analysis of a group of 600 patients, and what was shown was that while the pattern of recurrence is different, those who have the pleural peel recur mostly locally in the chest, those who have the extrapleural pneumonectomy recur mostly outside of the chest, but stage for stage survival is identical. And that data suggests to us that for those patients who don't have the criteria that would enable a cure, you can probably get much better quality of life by doing the less aggressive surgery and keep your lung in place. Now, this curve shows in red what surgery alone is versus what surgery plus other treatment adds. So surgery is not sufficient. It's fine, but you need to do something else. So what's that something else? Well, one of those potentially is radiation. And this is a tumor that's moderately sensitive to radiation. But if you aim the beam of radiation at the cancer, you hit structures around and underneath it, like the lung. And unfortunately, you're more likely to kill the lung before you kill the tumor if the lung remains in place. So the only time you can do radiation for meso, other than just to palliate a painful mass, is after the extrapleural pneumonectomy, the big surgery that removes the lung. A few years ago, people were very excited about a specific type of radiation called IMRT, or intensity modulated radiation, which supposedly focuses a great deal directly in one area. Unfortunately, it actually causes potentially fatal lung toxicity, and so we don't do that anymore. Now, what about adding chemotherapy to the mix? Well, this curve shows you that in those patients who have the less aggressive epithelial histology, they actually can be cured by doing the extrapleural pneumonectomy, the radiation, and the chemotherapy, whereas those who have sarcomatoid will not be. Similarly, patients with lymph node negative disease will do far better than those patients whose tumor involves the lymph node. So if we know this up front, we may be able to select the right patient for the more aggressive surgery. And right now, standardly, we usually give chemotherapy before surgery. That helps actually the tumor be removed more readily, and it may potentially decrease the incidence of tumor spread before you take the tumor out. And this is just a table of a variety of clinical trials that have been done that have looked at giving chemotherapy before surgery, doing the extrapleural pneumonectomy, and following up with radiation therapy. We're making progress, but it's still not enough. Moving on quickly to systemic therapy and some of the novel agents. Where are we now with chemotherapy for mesothelioma? Well, there are a number of what we call cytotoxic drugs that have activity in and of themselves, and most of these shrink tumors maybe 25% of the time. And these are drugs like pemetrexed or Alimta, vinorelbine or navalmine. A number of drugs can prolong survival, although unfortunately it's only by a few months, and that's by adding some of these drugs to other drugs like cisplatin. We can increase our rate of tumor shrinkage by adding a platinum to pemetrexed, raltetrexed, and the other drugs listed here. And a lot of research is being done in preclinical models, in mice, and test tubes. And many novel agents truly do seem promising, but not all of them have activity when we test them in patients. This is a list of some of the selected drugs and drug classes that are thought to have activity in mesothelioma. But if we look at the class of drugs that's most active, it's what we call the antifolates, including drugs like pemetrexed and raltetrexed. Now, these drugs we've discovered are active in mesothelioma. They get into the cell via a variety of carriers shown here. And in mesothelioma, these carriers are far more active than in other tumors, so the cells can take in these drugs far better, and that's why they work. If we can find out other drugs that are taken in better in mesothelioma, maybe we can utilize them in the future. So as a single agent, pemetrexed or Alimta shrinks tumors about 15% of the time. It makes many patients feel better, however. When we combine the drug with cisplatin, and this is the landmark trial that got pemetrexed or Alimta approved, it compared pemetrexed and cisplatin to a placebo and cisplatin. It shows us the value of placebo-controlled studies. And you don't have to squint too much to see a difference between the curves on here. We can see that the combination improves response rates to about 40%, and it improves survival and the time in which the disease stays stable or responds. But we give this drug not only because it makes people live longer, it makes them feel better. It improves shortness of breath, it improves pain, and it improves various parameters of lung function. And so it was these data that led to the first and as of yet only drug that has ever been approved for mesothelioma, pemetrexed or Alimta. But there are still a few things that we don't know about pemetrexed. When should we start it? If you're asymptomatic, should we give it to you? How long should we continue it? Should we keep giving it for months and months at a time, or should we stop after a defined period? We don't know when other drugs might be better, and we don't know when the cisplatin, that is a standard drug to give with Alimta, might not be the best drug. And so one of the studies that's just about to launch nationally is a study that will compare giving pemetrexed and cis or carboplatin, followed either by continuing the drug or stopping it and observing. In some tumors, the observation is superior. In other tumors, maintenance is superior. Hopefully, we'll be able to learn that soon from this study. And as I said before, 72% of the patients with this disease in the United States are over 65. So these patients can't handle the really tough drugs of Alimta and cisplatin. And for these patients, we generally will give pemetrexed and carboplatin. This has been shown to have similar survival, similar response rates, and doesn't throw you in the hospital, can help you lead a much better quality of life. Other drugs with activity include vinorelbine, widely used in the UK. Randomized studies have also shown it improves survival. Now, I've shown you some progress that has been made, but why haven't we done better? What are some of the obstacles we've encountered in developing new treatments for this disease, and where do we go from here? What interesting new agents are being studied? Well, several factors have hampered the development of effective regimens for meso. Unfortunately, most importantly, most drugs don't work. But the fact that this disease is uncommon, that it is heterogeneous with multiple different sites of disease, multiple different pathologic subtypes, makes it difficult. The staging is unreliable, assessing response is difficult. Why don't most drugs work in this disease? Well, part of it is that we don't understand the biology well enough to find the right drugs to test. More research funding is needed. The right drugs may be out there, but it's very difficult to persuade pharma to test them in an unprofitable disease. We need more funding. And drugs may work in the test tube, but not in the patient, because the drug isn't properly being delivered to the tumor or it's being inactivated in the patient's body. So more work needs to be done. Now, the fact that mesothelioma is uncommon has hampered research. Many trials are small, and this can lead to false positive and negative results. But more importantly, large trials are tough to complete, requiring many sites in many countries over many years, and we can only do so many studies. And important to pharma is that the potential market is small. So it is not profitable, and it becomes very difficult to interest pharmaceutical companies and grant funding agencies. But let's say that we do have a new drug. How do I even choose to test them? Well, we uncover through our basic science research various targets that have interesting preclinical data, and I've listed a number of them here: VEGF, SRC, c-MET, IGF-1R. Unfortunately, promising preclinical data has led to disappointing results, sometimes in patients. But our choice of drug is mostly based on what's available, what safety data exists, and the willingness of a drug company to let us test the drug. Despite all of these obstacles, this is just a partial list of some of the novel agents that are currently in clinical trials for mesothelioma, and they represent a vast variety of drugs in a variety of different scientific classes. And I'm just going to talk about a few given the limited time that I have. Now, this shows you what we talk about preclinical data, control versus those that are given the drug, and you can see even from across the room, it looks like this target works preclinically. But then when we give it to patients, maybe only modest results with this class of inhibitors, the VEGF inhibitors. But do we stop there? No, we do other studies. We do randomized studies in which we may add our drug of interest to another combination compared to a placebo. And sometimes we come up against what looks like a dead end. It doesn't look like it works. But then we look at various subsets of patients, and we may see certain biomarkers that may help us predict which patients may still have a drug able to work, and we do further research. One drug which may potentially become an agent that may become approved for mesothelioma is a drug called SAHA. It's a drug that inhibits what we call histone deacetylase, which is something that sits on the DNA and turns on and off genes. This drug shrinks tumors about 20% of the time, but makes about 70% of people feel better. And the currently largest trial ever being performed in mesothelioma is this 660 patient trial that's going on internationally and is about 3/4 done, and we can be hopeful. I talked to you about the biomarker mesothelin before that is circulating in the blood of patients with meso. Well, this becomes another target for treatment of mesothelioma, and there are a number of studies, including the Morabo 09 study that we have available at our institution that is being given in combination with standard therapy to see if we can make improvements upon the standard. And here you can see what it looks like in the test tube. That green line shows marked synergy between the anti-mesothelin therapies and standard chemotherapy. There are a number of things that are a little bit more out of the box, such as gene therapy, where mesothelioma may be a good target because it's a very localized disease, and so you can insert your gene therapy of interest directly into the chest cavity and do what we call suicide gene therapy to try to generate an immune response against the tumor and try to target it indirectly. And finally, a very novel approach that we're quite excited about, which is targeting TGF-beta, a growth factor that's released by tumors and white blood cells within tumors, and this is made at much higher levels in mesothelioma than in other tumors. And here you can see on that red line how interfering with TGF-beta really shrinks mesothelioma tumors. And a clinical trial of a drug that blocks TGF-beta is just about to open at our center and at the University of Pennsylvania. And the drug company didn't quite have enough money for this, so we actually got a charitable foundation to also donate funds so that this study could move forward. So what about hope for the future? How can we continue to make progress against this disease? Well, key is to understand the biology of mesothelioma, which will require more funding and lobbying for basic science research. We need to learn how to use the new biomarkers and develop new ones so that we can detect this disease early when it may be more curable. We need to learn how we classify the tumors, something that we call staging, which is an ongoing international project. We need to integrate our new knowledge about chemotherapy and radiation into our surgical procedures. And for chemotherapy, we need better drugs, we need to define our key questions, and we need to continue to evaluate new approaches. And for this, of course, we need a commitment from the pharmaceutical companies and the National Cancer Institute. And this is our program at the University of Chicago, one of the largest programs in the world dedicated to mesothelioma. And for those of you who would be of interest, as the president of the International Mesothelioma Interest Group, I'm delighted to announce that our meeting will be held in Kyoto in August, and those of you who can participate, we'd love to have you join us. Thank you very much.